Hi, I'm Dr. Matthew Norton, the founder of People Plus Purpose, and welcome to the Truth Behind Dentistry podcast. Today, my special guest is Tosha Kozloski. Tosha is a registered dental hygienist and a leading expert in periodontal care and modern dental technologies, specializing in virtual training that helps dental teams rethink their approach to chronic infection. She teaches providers how to identify and treat persistent bleeding, especially in patients whose signs of disease have been easily overlooked. By integrating microscopy and advanced techniques, she helps teams uncover hidden infections, improve diagnosis, and confidently guide patients toward real periodontal health. Welcome to the podcast, Tasha.
Thank you so much for having me.
And it's my pleasure. And I'm excited because we're going to kind of do a little different approach today. You've got a bit of a presentation for us. I'm going to show us some, I think, some interesting things. Before we get into that, I would love if you could just share a little bit about your journey to get to this point in the things that you want to share today.
Wonderful. Well, I would love to. So I graduated with the same technologies and tools that most of us have in our practices today. I've been a dental hygienist for 20 years, and I really was a super nerd in college and wanted to work for a periodontist, just thought I could cure the world of gum disease. And then when I got out into practice, I just found it to be such a persistent and difficult infection to treat. And it presented in so many different ways that I was extremely frustrated. And through just a lot of pursuit of there has to be a better way, I found a very like-minded dentist that was starting to do salivary diagnostics and was really looking at the different periodontal protocols and trying to figure out what are the causative components here. We can't just go around looking for calculus. And so through that, I was introduced to saliva testing, to microscopy, and then later on introduced to lasers and guided biofilm therapy and ozone and all the different tools that we have at our disposal. But where I found the biggest missing link really has been in just understanding what disease looks like in the first place, because most of us think of a dirty mouth, and many times it's a very clean mouth in patients that come in on a very regular basis, but it's that persistent bleeding. And
Mhm.
so that's where my love for microscopy and salivary diagnostics and all that has really set sail.
Yes. Awesome. Awesome. And it takes that, right? I mean, we have to keep having searching minds. Otherwise, we keep doing the same thing, running into the same dead ends, and probably underserving a lot of people um, because we've accepted this is as good as it gets. This is the
Yeah,
best there is, right? So
absolutely.
obviously, it takes people willing to kind of forge a new path, and I'm glad that's been you. And so great. Share with us a little bit what you have on your heart and
Awesome.
mind today.
Awesome. Well, I will share my screen and I will pull up a quick little presentation for us.
Okay.
All right. So the million dollar question really tends to be, what does periodontal disease actually look like? And so many of us think that we're effectively managing disease, but traditional methods, unfortunately, are really very reactive. We're waiting until there's destruction that's already occurred. And once destruction has occurred, that means that bacteria is very likely already in the bloodstream as well.
Mm.
And so we've all seen the study that was the largest study that was done over a decade ago that stated that a half of our patients by age 30 had already lost 15 to 30% of the jawbone that holds their teeth in. And our retirement community, we're well past 40% loss of jawbone from periodontal disease specifically. And
Mm.
that study didn't look at gingivitis. And so recently, a large study was done that found that 90% of the world's population has some form of chronic gingivitis. And so in my operatory, I certainly felt like that was true. I felt like the majority of my patients had some bleeding. Maybe it wasn't profuse like the image on the screen, but they certainly did. So, thinking about statistics like that, we should expect then that the hygiene operatories are pumping out some periodontal coating and doing a lot of treatment. But to compare apples to apples and jump back to 2012, what this large insurance study found, so this was a study that looked at the claims that we were filing in 2012 from lots of different insurance companies, and they found that from ages 19 to 34, we were filing 72% pro fees. From 35 to 49, nearly 86% pro fees. And the highest risk category that this particular study looked at was ages 50 to 64, 95% prophies.
Mm.
I think, for me, a large disconnect, I believe truly is that we think that this is what periodontal disease looks like. We think that it's in patients that don't get their teeth cleaned on a regular basis, that maybe don't have a value system for really taking care of their teeth, or they're just maybe lazy. But in reality, this is what periodontal disease looks like. It's in patients that do come to us regularly. That insurance study was done because patients were going to the dentist and we could track them.
Mm.
And so when we see mouths that look really clean, and we do our full mouth probe chart and we don't see any bleeding points or we see very few, we think, oh, it's probably just, a routine prophy. But all of these patients looked like this as soon as we got in there. It's a complete bloodbath. Some
Oh,
patients have minor bleeding, moderate to severe bleeding,
oh.
and the doctors aren't really off the hook either
Mm.
because you guys see it too. I mean, it's whenever we touch that gum tissue and it just starts to bleed, and not because we were too aggressive with the gums. So it really is very, very persistent in all of our operatories. And because of that, it's pretty easy to get normalized to it, to
Mm.
just assume that everybody has some bleeding. I remember telling my mom, who's a dental assistant, Mom, everybody bleeds. If you're doing it right, everybody bleeds.
Mm.
Kind of looked at me like, I don't think so, Tasha.
Uh,
That can't be true.
Right.
But really, what we know now is that like so much has changed in our understanding of periodontal disease, of the science behind it, what is truly going on. And science evolves so much faster than college curriculums can. So we really do need to rethink what we've learned. I mean, a couple decades ago when I graduated with blonde hair, my understanding was radically different than it is today. So, for really a risk of oversimplification, what we now understand causes periodontal disease is it's the host immune response in connection to the biofilm. And so, all of us are probably coming in contact with periodontal disease causing bacteria at any given time. So we know we can get them from parents, partners, our pets licking our mouths, but also contaminated food and drinking water. So if Thursday after work we go out and we have, a smorgasbord of appetizers with our friends and a few people are double dipping and we don't really know, you might be eating more than that appetizer. You
Mm.
might be eating some bugs on there.
Mm.
Bestie, goes like, "Oh my gosh, Tasha, I have this amazing cocktail or mocktail. Try it." And I'm like, "Oh yeah, I'll give it a try." How do we know that they don't have something swimming around in their mouth? Because clean doesn't equal healthy. So,
Mm.
going on the assumption that all of us are probably at some point or another going to come in contact with bad bugs, let's then think that we just left the dental office. We have the world's best dental hygienist. They did the best cleaning of your life. But as soon as you leave, that biofilm starts to reform again. So, as that biofilm forms, let's say that, life is stressful, we're not getting enough sleep, our hygiene protocols have slacked off just a little bit, and we get some plaque that's just hanging out at the gum line. Well, the body goes, "Hey, I don't want that there. Like, get out of here." And so the body tries to help us out and elicits an acute immune response. So what does that do? That acute immune response says, like, bring white blood cells to the surface or to that area of the gum tissue because white blood cells have an antimicrobial effect. The immune system has one more trick up its sleeve. It says start to flush it out. So it increases in the gingival curvicular fluid. So the spit in the pocket. So it's like disinfect, flush out, disinfect, flush out. But if we have bacteria in our mouths that are periodontal disease causing bacteria, they have a lot of superpowers as well. So we're all pretty familiar with what MRSA is, Staphylococcus aureus. Part of MRSA's superpower is that it's biofilm forming. So it's got this nice jacket around itself of this sticky, sticky matrix. And that sticky matrix has resistance to antimicrobial, resistance to antibiotic. It has the ability to cause disease in and of itself. The bacteria that cause gum disease have that same property. And so when our body tries to get rid of them, the bacteria goes like, "No way, man. I have prime real estate. I don't want to go anywhere." So it all just gets stuck there. So the body continues to release white blood cells. Well, before we know it, this gum tissue that's supposed to be nice and tight, like epithelial cells that are supposed to be nice and tight, gets swollen because they're so full of white blood cells. Now, all of a sudden, the gum tissue is leaky and permeable. So if you have periodontal disease causing bacteria in your mouth, it easily goes into the bloodstream. And I love what Dr. Daniel Sindler said about oral systemic. He said, when we look at the root cause of periodontal disease pathogens, the oral systemic connection becomes clear Periodontal disease doesn't crawl up through our nose and into our brain. Periodontal disease does not sneak across the placenta barrier and cause pregnancy complications. Heart disease is not periodontal disease located in your chest. Oral is systemic because of the pathogens.
Mm.
And he goes on to say that what research is finding is not that periodontal disease causes systemic disease. It's that the pathogens that cause periodontal disease may also contribute to systemic diseases. He
Mm.
said that over a decade ago, and we now know that to be true.
Mm.
57 at least systemic diseases have been linked to periodontal disease. Dozens of books have been written about it. These are some of my favorites. My personal favorite is Dr. Katie Lee's Safe by the Mouth. The best part about it is that she's already translated it into English from scientific nomenclature. So our patients can easily read this.
Mm.
I recommend it to every team that I work with. I just think it's such a fabulous book. Dr. Brad Bale and Amy Doneen wrote these two books. Under their care, they guarantee that you won't have a heart attack or a stroke. Oral health and how healthy your mouth is pivotal for that. And so really there's not a lack of evidence about what is now causing periodontal disease. The disconnect is the gap for our patients, the gap for the clinicians, really bridging that to help the clinicians understand what's causing it so we can better educate our patients. I feel like we bridge that gap really nicely in restorative dentistry. None of us would dream of practicing without a camera.
Mhm.
Because as we know, a picture is literally worth 1,000 words. We want to show our patients versus blab about what's going on when they don't necessarily understand what our scientific dental nomenclature is. And so Dr. Paul Kais really was the front runner on salivary diagnostics. He was an award-winning dental researcher. And the benefit of microscopy is really that the visual nature of it allows us to be precise, personalize the care, and it makes like an extremely compelling argument for the patient. Whether your patient is emotional based, they're not going to want to see those creepy crawlers, or logic. They also know that bacteria that are causing harm, they probably don't want them in their mouth. And so when we can see these bacteria, it increases the urgency immediately. It increases case acceptance because now the patient goes, oh, that's what you're talking about. You're telling me that I have an infection, not bleeding on probing pocket depths and this localized type problem that, let's face it, doesn't sound anything like an infection when we're talking about periodontal charting. And so it eases and it bridges that oral systemic gap. So I'm definitely not saying to get rid of our traditional diagnostic parameters. It's more about adding them to our traditional diagnostic parameters so that we can be more objective versus subjective. What Dr. Paul Kais said of using a microscope in the 80s was that it soon became apparent that there were striking differences between the prevalence of white blood cells, types of organizations, patterns of behavior. So it looks completely different. And although bacteria on a microscope can only be identified morphologically, so I can't say like you have Porphyromonas gingivalis, but he decided that all of these specific characteristics could be their therapeutic targets.
Mm.
So when we look at the slides, it's apparent which one do you want in your mouth?
Mm.
The ones on the right, like not the ones on the left. When we have a bacterial invasion, we have all kinds of creepy crawlers swimming on there. But when we have balance, we see healthy cocci, maybe a few non-motile rods, but it's kind of boring. There's not a whole lot going on. And so what Dr. Kais talked about with the difference of his approach was he stated that periodontists talk about eliminating the anatomical defects and monitoring the results with their probes. We eliminate the bacterial risk factors and monitor the results microscopically. How else would we know that we've controlled an infection? So when we can show our patient a microscope slide with lots of creepy crawlers on it, patients go, oh my gosh, that's in my mouth. Dr. Norton, what are you going to do about it? So they get it like that.
Mm.
And so when it comes to how to take a slide, taking a slide takes less than 30 seconds. It's really fast. You just grab a piece of plaque from their mouth, preferably subgingival, because we want that sticky stuff that's attached to the tooth. And it takes about a minute to 2 minutes to just explain your findings to the patient. So it's very reductive in the periodontal disease conversation. For me, I would spend no less than 10 minutes trying to explain why a patient had periodontal disease, this asymptomatic problem that they didn't know they had until I poked their gums. And then all of a sudden I'm telling them that they need over $1,000 worth of treatment. Whereas this is, I'm finding something different, so we need to do something different. So it's really 3 different types of slides that we're looking at. So healthy means great, green means go. Prophy, perio maintenance, continue on your merry way. If we see a moderate risk slide, it doesn't look that bad, but we can see an uptick in specific bacteria. What that means is maybe we need to reevaluate their home care, give them some home care tools and tricks to do a better job disrupting and disorganizing that biofilm. Maybe it's a patient that has sleep apnea and they stopped wearing their CPAP. Well, of course, their immune system's going to be tanking if that's the case. So there's some tweaks and modifications we can easily do at that point. But if we see a high risk slide, that's an indicator that the patient absolutely needs more than a prophy or a period maintenance because they already have too much dysbiosis. Their immune system is already waving the white flag, so to speak. And this is very similar to what we already do for restorative dentistry. If somebody comes in for a comprehensive exam, we take boatloads of photos and scans and x-rays and we chart everything that we see. Why? Because we want a snapshot in time of what things look like today. We want to show our patients, not tell them. Just like at a routine appointment, if we see with our eyes a fractured amalgam, we're going to take a photo so that we can show them. But we're not just going to do that. We're going to take an x-ray. Is this a superficial fracture or is this patient at risk for needing a root canal? We can take that one step further. We see on a PA that looks like some radiolucency there. And as we all know, then we look at the cone beam and it's like, whoa, that's like more than 50% worse than it looked like once we see that three-dimensional image. So this process is really very similar. We see any signs of inflammation or bleeding. You don't even have to wait till you see a sign. You could take it on every patient. But I will say that most practices don't because there's more therapy than they usually have hours in their schedule. And
Right.
so, but if we see a problem, we simply say like, hey, Dr. Norton, I'm seeing some changes in your gums today. You have redness, inflammation, and even bleeding. I think you might have come in contact with some bad bacteria and your mouth got sick. Then we take a microscope slide. We show them the creepy crawlers. Wow, this definitely explains the changes I was seeing in your gums today. Think of these bacteria like termites in the foundation of a house. They live deep down inside your gum tissue, not just on top of it, which is why coming in here regularly, doing a great job with your home care isn't going to take care of it. And of course, we can even take that one step further by doing a lab test. So it just puts that entire process together so that patients can really understand and own their infection and be a willing participant in that entire process so that it's not just us saying, you have, you have, you have. And they're like, I didn't know I had this problem until I came here.
Right.
Maybe
Yeah.
I don't need that. Can you just
Right.
clean your
Yeah.
teeth today?
Yeah. Yeah. Wow. That was awesome. I'm not even sure where to begin.
Great, great.
I think, I mean, I agree completely in that this is not understood, right? That to expect patients who have never been informed about any of this, maybe a lot of times because their dental healthcare team didn't know the language, didn't know what they were seeing and looking for at the highest level, maybe with the
Yeah.
latest research. Um, so, and I think people do tend, relative to the case acceptance piece, or what their follow through is going to be with anything is the lack of clear understanding either leads to a bunch of overwhelm because you're telling me stuff that I don't really know what to do. I don't know what the answer is for any of this, or uh, it doesn't make sense to me. It just seems this seems like so mysterious. I don't know how
Yeah.
to say yes or what to grab a hold of. So I love the whole approach. I guess I'm curious first, like how prevalent is your approach using these insights becoming? I mean, how far do we have to go as a profession to get to a level to where people enough practices are doing the best in this area?
We've gotten a lot better, but we still have a ways to go. I mean, in terms of statistics, we're not treating even a fraction of disease that's out there. And I think a large part of it is really the way that we communicate with our patients. So whenever I work with a practice and they're like, Tasha, I want to implement a microscope, I say, that's awesome. But first, we have to look at how are you communicating with your patients?
Right.
Because we can't just shove a slide in front of them. We want to use very specific vocabulary. We want to use analogies that they already understand. And so if we can simply start to communicate more like a healthcare provider would,
Right.
not dentistry focused, then patients start to go, oh, I understand that. I've had other infections before. I understand how I could have probably come in contact with something and my mouth got sick. Like that makes a lot more sense to me. So, in terms of microscopy, I think it's gaining a lot more momentum and speed now and in popularity just because there's a lot of different people that are promoting it more so that we're getting more used to it. And the technology has gotten a lot less expensive. I mean, microscopes used to be really expensive and difficult to use and read. The images weren't quite as good. Now, I mean, you have such a great image. It's very fast, easy, and effective. And when we have a lot of tasks to do and we're asking our hygiene team to do one more thing, if it's not really going to enhance like the level of care and their understanding, they're
Right,
probably not going to do it.
right,
So we really have to make sure that if we're going to add a tool or a technology, that it's absolutely necessary and it helps us. It's not just like, oh my gosh, it's another thing.
right. Yeah. I've always, since I very first heard about oral systemic health coming from a healthcare background myself, uh, that gets me excited and understanding the connectivity between all parts of the body. And then I often thought that the dental profession was way too siloed when it came to understanding it's like the mouth is a completely separate thing that's not even, I guess, connected to anything else, right? And and I've thought that that hygienists had kind of a unique opportunity to be that larger healthcare messenger within the office because the doctor I'm imagining, and you can answer me on this as far as the doctor's change in language, the doctor's orientation to this portion of the practice and to care. But I've often felt like it was the hygienist who had that time on some
Yeah.
regular basis to be advancing that. And I also have thought that there's the segue, kind of the connection into other healthcare providers, even in their
Yes.
community, that could be very beneficial for the patients, but also for the practice itself in developing that larger network of kind of collaborative health partners. What's
Yes.
your sense of any of that I just said?
Yes, I totally agree with everything that you just said. And when practices can understand the causative components of the infection, it makes so much more sense to connect the rest of the body. For me personally, when I was a young hygienist, I knew theoretically that diabetes and periodontal disease were linked, but I had no clue how to talk to my patient about it,
Mhm.
or heart disease or any of those things. It was like this giant gap that I was not able to fill. And or articulate maybe would be a better way to put it. When I started using a microscope and doing salivary diagnostics, and I could see the changes and I could see the inflammation and I could show my patients, and then I could say, like, hey, you have an infection. That infection isn't just in your gums, there's an entire inflammatory response. We all know that inflammation is not good for our body. And so that's how this is related. And so when I could keep it in, baby steps for my patients.
Mhm.
But then when I had patients that didn't get better, regardless of us doing everything that we knew how to do, we took them to gum tissue therapy, we used antimicrobials. Sometimes we even used systemic antibiotics when it was a really persistent infection. And if we still couldn't get them better, we were immediately making them a referral to a physician or to all different, different types of professions. I've referred directly to a cardiologist before
Mhm.
because what the patient was telling me, because like you said, the hygienist does have more time
Mhm.
than almost any other industry has with
Mhm.
how frequently we see patients and how much time we see them for. And I get that we have a lot of tasks, but our patients, they talk with us, they share a lot of things.
Right,
We get to
right.
know them so well on a
Yeah,
personal level.
yeah.
And so those referral sources with a program like this are critical because we do end up with patients that are not getting better, or we have a patient that has cancer. And now we know that certain pathogens can actually grow those tumors.
Mhm.
So if we don't get their bleeding gums under control, it can actually make things like that worse. So
Yes,
how great to work with their oncologist and say,
yes,
hey, we need to do work on this together.
yes. Yeah, that's great. I think also thinking about the unique, compelling contribution that any given practice, any given business provides, right? What they talk about, the unique selling proposition, right? Is the more common language, but I like unique, compelling contribution as better languaging for that. But in terms of like why us, why this practice, why should they come here? Uh, how do we stand out? And I think, especially like for those practices that are saying, I don't want to be even like insurance dependence is something I would like to move away from some. But again, how do we feature uniqueness about us in our offering, in the environment that we've created here so that we can compete, say, against
Yeah.
cheaper, maybe somewhere else. And to me, it always seemed like this provides a strong case for that, or is at least a key
Yes.
piece of that. Does that seem right?
Yes, I agree. It's that whole health approach that so many people are looking for right now. I mean, that whole health approach when we think about in medicine and thinking about functional medicine, it's the fastest growing industry right now. And it's because people want to take control of their health. They want to know what they can do for themselves and for that. And so when practices invest in themselves and saying like, hey, there's a missing link here. We've been doing the best that we can, but now we know more. So
Right.
now we need to get educated and see like what else can we do for our patients to get them better? Because yeah, we do have patients that they've had a 5 millimeter pocket for 5 years, but golly, they are bleeding all the time.
Yes.
And that patient also has rheumatoid arthritis. I wonder if there's a connection there. What
Mm,
about my psoriasis patients? And all of a sudden it's like,
right.
wow, there's such a huge opportunity here to help our patients get better. And one of the things that I love so much about what I get to do is practices will call and text and they'll say, "Oh my gosh, we had a patient come in today. They were finally able to get pregnant. Oh my gosh, this patient, got off their steroids. They know their rheumatoid arthritis is no longer painful."
Mm.
These huge success stories. And the people within the practice are saying, "I finally feel like the healthcare provider that I set out to be."
Right. Yes.
Hallelujah.
Yeah. Yeah. That's great. I also think too that like the whole hygiene shortage challenge, right? Like it seems like, especially since COVID, that we've run into more of a kind of a business model
Yeah.
crisis to where what hygienists are asking for in terms of their pay combined with the difficulties in keeping hygiene schedules full a lot of times that there's answers in what we're talking about here. And I've thought, so how does the model change? Um, how do we have that be more worthwhile to the larger success of the practice to be willing to pay those, to be able and willing to
Yeah.
pay those wages? Because the larger contribution to the practice from the hygienist in realms like this seems to make sense to me. Uh,
Yeah.
does that fit with your experience as well?
Yes, I totally agree with that. And
Mm.
it is the hygienist shortage is I wish it was going away sooner than it's going to be, but we're looking at the next 5 to 7 years to be a fairly tricky situation. Um, I do find that if a practice is very whole health driven. Statistically, every office has periodontal disease. If practices think that they don't, it's just a fundamental misunderstanding
Mm.
because we just all do. I mean, even myself, I was treating tons of perio. I had really high conversion rates and patients were
Mm.
going through treatment, but a lot of patients don't stay healthy forever.
Right.
And there's such a misconception there. And so what can happen with a program like this where you're really looking at periodontal disease? You are doing so many more SRPs, which of course are going to be a very large change. So let's say that your average hygiene visit for an hour is $225. You're now pivoting that to couple 90-minute visits that are over $850 a piece. The patient's going to need two of those. I also train to add a follow-up so that we can ensure our patient is getting better, make some tweaks and modifications before we set them through 3 to 3 months. So production typically ends up easily doubling if you're a very prophy heavy practice.
Mm.
Even your patients that are in perio maintenance, as many of them do need to go through therapy again, even if they've been seeing you religiously every 3 months with perio maintenance, because if they're still bleeding Yes, we do use a scaling and root planing code, but that encode is inclusive of removal of bacteria and toxins. They
Mm,
don't have to have calculus. So
right.
there's a lot of misunderstanding in like what are we doing and when. So
Hmm.
essentially, the hygienist can see less patients
Right.
and produce far more. And
Mm,
then they're more fulfilled at work. So they want
yes.
to stick with the same practice. They don't want to temp around to make more money.
Right.
They want to stick with that practice where they feel like they are given the tools to
Yes.
thrive,
Yes.
not to survive.
Yes.
But I do have other practices where they cannot find a hygienist to save their life. And so they maybe have like a 1 to 3 ratio, meaning like a one hygienist to 3 assistants, and they're doing assisted hygiene, which some people go, oh my gosh, assisted hygiene, it's terrible, but it can be done so well.
Mm,
Assistants can be just such a gift to us. They
mm,
can triage, they can use airflow, they can assist with taking slides, they can prep the patient in the entire conversation based
yes.
on x-rays and photographs and taking that slide. Then when the hygienist comes in the room, they have a transition conversation. Tasha doesn't need a cleaning today. You know what? She actually came in and she came in contact with these bad bugs. Her mouth is sick. So, really, we need to talk to her more about gum tissue therapy. She needs a medicated cleaning. I explained to her that the cleanings we've been doing is like a routine car wash. But what she now needs is more of that full detail, really spending time getting in the nooks and crannies, places we just can't reach with a traditional cleaning. Changing that entire conversation to where the assistant is not diagnosing. She's
Right.
handing off that information. The patient's
Right.
hearing it again. And then the hygienist goes, oh, we need to get Doc in here to
Yes.
confirm. Yep,
Yeah.
I see what you're talking about. So
Yeah.
it helps the entire transition to
Yes.
you make more money because you're doing the right things for the right
Yes,
reasons.
yes. It's like there's a higher vision there, vision, mission of what we're really seeking to accomplish and building
Yeah.
a stronger business model around that bigger vision, as opposed to a lot of the ways that we're kind of, it feels like kind of fighting, kicking and fighting to not change some of those things. And
Yeah.
we're having a hard time dealing with the personnel issue, et cetera, as a result of that. And it's not financially feasible a lot of times
Yeah.
seems to keep going like this. So I have one more question for you before we wrap up, and then I want to have you tell our viewers how they can get in touch with you and get more information about what you're providing. But why, given all of this, given the research, given um, the possibilities for greater revenue, greater uniqueness in offering, better health. I mean, what's the holdback? What do you feel like would stop from the microscopy component being integrated, or even beyond just microscopy, even taking more of a view like this? What do you think are the key issues that are holding back?
I think the number one issue is fear. It's not going to work for me. And also fear of telling your patients that a lot of clinicians feel like, oh my gosh, my patients are going to find out that I haven't been doing a good job. And it's not about that at all.
Hmm.
I know that we're all doing the best that we can. And like Maya Angelou said, you do the best you can until you know better. And then when you know better, you do better. So
Right.
it's a lot of fear of introducing new things to our patients. And so what I tell teams like that is even if you have patients that have 5 and 6 millimeter pockets and they've not gone through scaling and root plane or they've not gone through treatment, you don't have to say like, oh, sorry, Dr. Norton, like I know you had these pockets before. We simply just start over. We say, hey, I'm seeing a change in your gums today. You
Hmm.
have redness, inflammation, and even bleeding, and move forward. Just move forward. We have to start somewhere. The
Right.
infection that you have is bacterial in nature. You came in contact with bacteria. It's not your fault, but we can get you better. And so that really that transition. For other practices, they have invested in lasers or they've invested in airflow. They've invested in lots of different technologies and it sat there collecting dust. And the provider thought, well, if I bought all these things, my hygienist will surely use them.
Right.
But the problem there too lies in when do I use it? Why do I use it? How do I talk to my patient?
Right.
So there's a foundation that is missing with some of
Right.
these tools and technologies,
Yeah.
and that I have found. And so for me, I don't train on the technology first. We train on the verbal skills, the understanding. How do I communicate this with our patients? What exactly are your protocols? How do you build them and get paid for your valuable services
Yes.
so that we can really know I see this, I do this. I see this, I do this. It becomes so black and white.
Yeah.
And
Yeah.
it's like we all get decision fatigue at the end of the day. Like, that's
Right.
not what we want.
Right. Yeah. Yeah. That's true. Just the addition of more tools does not necessarily mean something got built, right? So,
Yep, exactly. Exactly.
so tell us, I appreciate all of this. I think this is a very important message, and I'm so thankful that you came on and shared it with us. So, how do people get in touch with you, and what's the first step?
Yeah, so they can go to my website, which is www.tosh.care, C-A-R-E. They can learn more about me on there, or just really shoot me an email, which is Tosha, Tosha, at tosh.care again. So I'm happy to answer any questions. I do virtual training. I also have a live event coming up. So I have a great Instagram page at tosh.care. It has lots of geeky, nerdy stuff, microscope slides, tidbits to help your patients. So those are probably the best ways.
Yeah, who could resist some geeky slides?
They're my personal fave.
Yeah, yeah, yeah. Well, thank you so much. I think this is such powerfully important information, and we need to keep advancing it. And I think you're a great voice for this. I think that was very, very well assembled and very hard to resist. So,
Thank you.
yeah. So, thanks everybody for watching. This is the Truth Behind Dentistry podcast. I've been with Tosha Kozloski, and please reach out to her and learn more. And let's keep advancing dentistry, and for the sake of our patients and for the sake of greater business success in the process. So, thank you for your time. Look forward to seeing you on the next episode.